So when we look at the primary endpoints, the keynote trial, the complete pathological response was about 64.8% compared to 51.2% on complex. So this is a significant 14% of improvement in patients achieving a new complete pathological response. Does it make a difference if there was a PD-L1 positive or negative? The difference was maintained between the two groups. If you look at it, they still maintain about 14% in the PD-L1 positive and about 18% in PD-L1 negative group. So event-free survival, has it improved? You can see the difference between the two groups. It was 84.5% showing improvement in event-free survival when we add pembro to the chemotherapy compared to chemotherapy on its own. This is the main from the trial published, which shows the significant benefit of complete pathological response going up to 64.8% versus 51.2% with chemotherapy. And when we add immunotherapy, event-free survival was about 91.3%. This is significant in terms of breast cancer. We have to acknowledge that grade 3 adverse events are more with immunotherapy, but they were comparable and manageable. So let's have a quick look at the Keynote 522 and NG-PA trial. So we have to keep in mind when we use the durvalumab compared to pembrolizumab, was there any significant difference? The main thing which we can see is the addition of carboplatin chemotherapy backbone, which is important to the triple-negative breast cancer, as we have discussed previously. And addition of immunotherapy doesn't make a difference in adjuvant setting as well. So these are the two major differences that we have to look into. And this one also shows that either any of the factors stands out and have benefit the patient most in event-free survival. So you can look at it, all the group were going towards the left side, your left side most likely. So that shows that all of the group benefit irrespective of their any other markers, nodal status, tumor size, and type of chemotherapy, PD-L1, age category, all benefit, although anyone with more than 65 years of age and having an ECOG performance status 1 crosses the threshold of 1, but still they were more favorable towards the immunotherapy. So what is the flip side of immunotherapies? We know, and we always been afraid of immune therapy related side effects. When you include common ones are the infusion related ones, which can be managed very easily with inducing the pre-treatment medication, followed by hypothyroidism. The pattern is they usually have a little bit of hypothyroidism. When they burn out, they usually go hypothyroid. And then severe reactions, adrenal insufficiency, pneumonitis, thyroiditis, hypophysitis, colitis, and all the itis that we know. So we have to keep an eye on a patient when they come in for immunotherapy. We constantly monitor them more vigorously and then keep an eye on any of the side effects emerging and try to treat them early. The treatment scheme is usually grade 1, mild. We carry on with the treatment with symptomatic therapies. If they're having grade 2 or grade 3, we have to think about starting the steroids, which usually in the form of 1 to 2 milligram per kg per day or equivalent, or slowly taper them down when their adverse event has gone to grade 1 to 2. For some adverse event, treatment can be restarted after resolution. People have to consider patient to patient. Usually it is contraindicated if you develop grade 3 toxicities. But I have started some patient and they have tolerated well. So it has to be patient to patient individual, and you have to discuss risk versus benefit ratios. So let's have a quick look about the Impassion 031 trial. Here you can see using nab-paclitaxel with dose-dense AC with atezolizumab or placebo, then going on for surgery followed by atezolizumab for about a year. And it has a quite, they were allowed to have adjuvant treatment further down with the residual disease, which including systemic therapies with the physician choice, which included capecitabine, other treatments, olaparib, other targeted estrogen, as well as endocrine therapy, which is in triple negative, would have to look into it. So the outcomes has shown that immunotherapy has an effect in survival as well as disease-free survival, numerically favored the atezolizumab containing arm. So once they've gone through the neoadjuvant, now we've proven that we have significantly improved the response rate, complete pathological response. What should we do if we have a patient with residual disease or high-risk patient who needs more treatment? What are the other options? I cannot go on without talking about CREATE-X trial, which is the adjuvant trial with or without capecitabine for patient with residual disease. And it was a Japanese trial, but has shown significant benefit. The trial was terminated early because the capecitabine group showed significantly longer disease-free survival, 74 versus 67% at 5 years, and overall survival was 89.2 versus 83.6% at 5 years. And it is becoming a standard approach towards adjuvant treatment. In patients with triple-negative breast cancer, capecitabine further improved disease-free survival and overall survival. Other option is Olympia trial, which defined the use of PARP inhibitor in patients with triple-negative breast cancer who have BRCA mutation 1 or 2. And when we use them as a 300 milligram BID for 1 year versus no adjuvant treatment, they tend to do better. This trial has a very balanced distribution in both arms. And when you look at the improvement in invasive disease-free survival, it was at 36 months, 85.9 months versus 77.1 months. And again, in triple-negative breast cancer, which was very aggressive cancer, has proven at worth that we can still treat them, and we are going towards the approaching towards the cure of these groups. And we can see the overall survival has also shown improvement. So what should we do if you got a triple-negative breast cancer? So consideration in the treatment for early stage triple-negative breast cancer is if you have T1C and 0, neoadjuvant treatment can be considered, but we're just going to consider taxane and platinum-based versus taxane and AC versus TC. And if they go on for surgery and have complete pathological response, they can continue with either 1 year of pembrolizumab, but you have to be considered either if they have a no complete pathological response, then you can think about other adjuvant treatment. If they have a high-risk group, where like tumor size more than 2 centimeter and node positive, then we have to consider immunotherapy in this group, followed by surgery. And as shown by Keynote Trial 522, we have to consider pembrolizumab, which is becoming more like a standard of care, followed by surgery, and then again, risk stratified either with a residual disease or no, then that you can think about other adjuvant treatment. So clinical question, although we have come quite a long way, but still, as we travel, we get more questions. So for neoadjuvant immunotherapy, does everyone benefit? Can we selective or highlight the people? Biomarker selection, balance the risk versus benefit, cost ratio, balance the risk and toxicity, who can avoid immunotherapy, who cannot, or tailoring more treatment. And then think about adjuvant treatment combining with immunotherapy. Are there any trials? Optimal duration of immunotherapy in patients who achieve complete pathological response. Should we stop early or carry on later on? Optimal impact of adjuvant immunotherapy. Does it need it, or we don't need it in the patient who have complete pathological response, or we need to escalate them? And chemotherapy backbone, should we accept that platinum along with anthracyclines and taxanes is the standard of care? And we have to consider those treatment in triple-negative breast cancer. Antibody-dependent antibody conjugates, such as trastuzumab govitecan, trastuzumab deruxtecan, datopotamab deruxtecan, all these things are also being looked into neoadjuvant setting. Are they going to benefit it and have a role in neoadjuvant treatment as well as in adjuvant treatment? Now we have to look at the stratified according to the mutation, such as BRCA1 and 2 mutations. Now we're thinking about P10 mutations and other mutations as well. All these things we have to look into and find the answers. Still, we have to cover lots of ground to complete our path. We are almost going in the right way, but still quite far we have to travel. Thank you. There are a few other slides, I think, for the time point of view. I'll ask my colleagues to present. I think
Thank you very much, Dr. Habib
Dr.
Khan.
Imtiaz Khan. I don't think so we can hear Dr. Abdullah Bukhari at the
Hi,
moment.
can
I
you
will invite Dr. Imtiaz Khan to come and present his thing. Thank you.
can you hear me?
We can hear you now. Yes.
Thanks a lot, Dr. Habib Khan. It was an excellent talk. Our next speaker is Dr. Imtiaz Khan, who is an assistant professor at University of Saskatchewan, Canada. He will be giving a talk on early stage HER2-positive breast cancer.
Assalamu alaikum and good afternoon, everyone. And thank you for people who are joining here live in person, as well as the audience who are joining us virtually. I'm a medical oncologist in Canada, and I had a great experience of working in Shaukat Khanum, Peshawar briefly a couple of years ago. And I must say that you have excellent faculty here, and I thank the organizers for giving me the opportunity to speak here today. So these are my disclosures. And today I'm going to divide this talk into a few sections. First of all, we are going to talk about the neoadjuvant treatment of HER2-positive early breast cancer. Then we'll move on to the adjuvant treatment of HER2-positive early breast cancer. And after that, we are going to look into the patients who have received neoadjuvant treatment, what choice of adjuvant treatment we can give them in that scenario, and what are the options. And then after that, we are going to talk about what extra treatments after HER2-based therapies and chemotherapy we can do to improve the survival further. During this talk, we'll be going through where we can de-escalate or escalate our treatment according to the risk factors. So I'll go through the scientific data, but the key clinical questions here is what are the considerations for neoadjuvant therapy in HER2-positive breast cancer, and what are the recent advances? What guides our decision for de-escalated approach versus escalated approach, and how many distant relapses we can potentially save by escalating the treatment beyond chemo and trastuzumab, and what are the remaining questions on optimizing adjuvant anti-HER2 therapy. So first of all, we'll start with the neoadjuvant portion of the talk. So which patients we will consider for neoadjuvant therapy and how it may improve. So it may render the inoperable tumor operable. It may allow downstaging from mastectomy to breast conservation surgery, and may eradicate micrometastatic disease and reduce tumor shedding during the surgery. And it allows for rapid clinical response and assessment while they are undergoing treatment. This slide gives you an overview of the different trials in the neoadjuvant setting and their outcomes. And from all of them, you can see that the PCR rate, pathological complete response rate, has almost doubled by introducing Herceptin compared to the standard chemotherapy. We must be mindful that these trials have different groups of selection criteria. For example, in some trials, the pathological complete response is defined in the breast only, while in other trials, it is including breast as well as any lymph nodes in the axilla. And we do know that PCR pathological complete response is associated with improved survival. However, PCR is not validated as surrogate endpoint for event-free survival or overall survival. What we do know is that introducing HER2-based treatments improves improves PCR rate, and in patients who have achieved PCR, they have much better event-free survival. We do also know that the hormone receptor negative patients, they actually drive much better PCR rates compared to the hormone receptor positive patients. So this NewsFair trial had demonstrated a very excellent comparison of pathological response in different regimens. So the standard arm here was docetaxel with Herceptin, and the experimental arms were additional pertuzumab on top of it, pertuzumab and trastuzumab together, so dual anti-HER2 alone, and pertuzumab as well as docetaxel. And we do know that the last two arms did not as good. The standard arm was better than those, but aiding the pertuzumab definitely improved the PCR rates in the breast as well as total complete response, which includes axilla as well. From this slide, between the two arms of the standard docetaxel and Herceptin versus additional pertuzumab on top, we do know that the pertuzumab provides additional 40% benefit in between the two arms. However, the p-value is crossing 1, the hazard ratio, and there is definitely improvement in disease-free survival, but you need to select which patients you are going to include for additional pertuzumab, because some of them may not benefit from it. So in summary, there is definitely correlation with overall survival and progression-free survival and PCR status. But PCR is not recognized as a validated surrogate endpoint for event-free survival or overall survival. Dual anti-HER2 targeted approach leads to improved PCR rates, but one may consider this approach to higher rates of local regional control in high burden disease. So those are the group of patients in which you will actually be more arguing for additional pertuzumab versus the early stage low burden disease. They may not benefit as much. Neoadjuvant dual blockade HER2 has led to higher PCR rates in clinical trials. Now, moving on to the adjuvant portion of the HER2-based treatments. So these are the different studies which over a period of over a decade, they have demonstrated that disease-free survival as well as overall survival have significantly improved with very highly statistical significant p-values as well as very decent hazard ratios. And here you can see that the disease-free survival as well as overall survival has improved, and this is 10 years of follow-up. And in this trial particularly, the key point is this is assessing trastuzumab extended duration of 2 years versus the standard 1 year and versus observation. And here you can see that the two curves at the top, they are pretty much overlapping each other. So the 2 years trastuzumab arm and 1 year trastuzumab arm, they are pretty much overlapping each other, meaning there is no difference. In other words, extending trastuzumab beyond 1 year actually is not providing any additional benefit. Observation arm is obviously definitely inferior. Again, this one demonstrates the nodal function and hormone receptor status. The higher lymph node burden, high risk disease, the more benefit it is, the higher magnitude of benefit it is driving. Again, it is demonstrating both ER positive or PR positive versus triple negative. All of them are driving benefit by additional Herceptin or trastuzumab. So what additional advances in the treatment of HER2 positive metastatic breast cancer? So affinity trial, this looked at intensification of treatment in addition to the standard chemotherapy and trastuzumab. If we can aid pertuzumab, does it lead to improved outcomes? And here we can see that invasive disease-free survival, there was definitely some improvement in that, more so in node positive group than node negative group, as we know that is a higher risk group. Hormone receptor positive group didn't do as well. As we discussed earlier, the hormone receptor negative group drives more benefit. But if we look at overall survival, no difference in the first interim analysis. Second and third interim analysis, some very small improvement in that. And that is after 8.4 years of median follow-up. Safety profile, with additional pertuzumab, you are obviously concerned if you are adding more toxicity. But actually, we see that the toxicity difference is very small, 0.3% with trastuzumab and 0.7 with dual anti-HER2 therapy. Diarrhea was significantly more in the patients who had non-anthracycline regimen and obviously the pertuzumab. These are different populations. Some have higher lymph node burden disease, some are hormone receptor positive, negative. So just to be appreciating that these characteristics across the various trials can be dissimilar. This just shows the improvement in disease-free survival and invasive disease-free survival over a period of time by aiding different agents. However, for the additional, for the pertuzumab, we do know that node positive dual blockade definitely helps with the node positive breast cancer, HER2 positive. So now moving on to post-operative therapy for patients that do not achieve PCR. So in patients whom you have given neoadjuvant treatment, you have done the surgery, and now there is residual disease. They haven't achieved complete pathological response. So this Catherine trial addressed that issue. What it does is early breast cancer, HER2 positive. They had preoperative neoadjuvant treatment with taxane along with Herceptin. They had surgery. They were randomized if they had residual tumor to trastuzumab versus T-DM1. And here we see that the invasive disease-free survival, distant recurrence, as well as overall survival have improved by T-DM1 compared to the trastuzumab. In the subgroup analysis, all of the arms, the T-DM1 is doing better across all the different parameters that you look. The T-DM1 is doing better compared to trastuzumab in those patients who have not achieved PCR. So how many distant relapses potentially can be saved by escalating treatment beyond chemotherapy and trastuzumab and HER2-based treatment? So after they have done adjuvant chemotherapy, adjuvant phase of their treatment, what extra we can do to further improve their outcomes? So these patients, in this ExeNet study, they had completed trastuzumab within 1 year prior to entry to the study, and they were either lymph node positive or non-PCR achieved. They were randomized to neratinib versus placebo for 1 year and then followed up. And we do know that there was an improvement in invasive disease-free survival, as well as there was a much greater benefit in the hormone receptor positive group. Normally, you will think that the hormone receptor negative is more aggressive and they have more response to the HER2-based treatments. Actually, here, the hormone receptor positive group drive much more significant benefit. And it is mainly for what we call a triple positive breast cancer that this provides significant improvement. Here you can see the number needed to treat in the hormone receptor positive subgroup is 23 compared to 1,000 in the hormone receptor negative subgroup. So coming to the adverse event, the main significant issue with this trial was grade 3 diarrhea, but that has improved since with actually starting with a reduced dose as well as prophylactic antidiarrheal medication, and gradually increase the dose, and this is much better tolerated. So in summary, individualization of target treatment by risk of recurrence has substantially improved the outcomes for patients with HER2 positive early breast cancer. Despite the impact of trastuzumab-based chemotherapy based treatment, there is 30% of HER2 positive patients, including node positive patients, who continue to have disease relapse. Benefit of dual blockade in adjuvant early breast cancer in some patients who are at high risk of relapse due to lymph nodal involvement, and extended treatment with neratinib leads to improved DFS, especially for the hormone receptor positive, high risk HER2 positive patients. Now, this is just summarizing a few of the trials which we have discussed. So how we decide about escalating or de-escalating the treatment, and from the HERA trial we saw earlier. maybe the pointer is not working. But from the HERA trial, basically the 2 years of Herceptin didn't do as much benefit. 1 year remains standard. Catherine trial, TDM1 for residual patients with not achieving pathological complete response. The TDM1 is definitely better to trastuzumab. Exinet, we discussed, this was the neratinib after completion of adjuvant trastuzumab. Escalating efforts, now coming to de-escalating efforts. Again, there can be various ways of how we do it. We go with non-anthracycline-based chemotherapy. We avoid anthracyclines. Or we reduce the duration of the adjuvant trastuzumab. So what guides our decision to use a de-escalated approach? For escalated approach, obviously the higher risk biology, node positive, locally advanced or inflammatory breast cancer, they have not achieved PCR or they are resistant phenotype. For de-escalated, again, it is the opposite, tumors with less aggressive, less tumor burden, early stage tumors, node negative, patients who have achieved PCR. These are patients whom you expect to do better, and for those we can de-escalate the treatment. So in de-escalated approach, obviously this is APT trial. This is using paclitaxel with trastuzumab for a total of 18 cycles. Paclitaxel for the first 12 weeks and trastuzumab afterwards for a total of 18 cycles. These were all ER positive, HER2 positive, node negative, less than 3 centimeter tumors. And we can see that the overall, this is 7-year update, but now 10 years update is there. And the overall survival is in the range of 94%. And breast cancer specific survival is in the range of 98%. There is another trial that TRAIN2, again, that demonstrated that non-anthracycline based treatment with TCH has improved outcomes in the early stage. These are the different trials that the regimens that they have used in these trials. So we'll first go to this FAIR trial, and this was randomization after 6 months of receiving adjuvant trastuzumab, whether you stop or you go on to continue to 12 months of trastuzumab. If we look at this trial, the intention was non-inferiority trial, which it did not demonstrate. The trastuzumab was still superior. So this was a negative trial. The FINHER study, again, the overall survival, this was non-inferiority trial, and again, it didn't show non-inferiority. The trastuzumab arm was better. Short HER trial, again, the same thing, non-inferiority was not achieved. Results were worse for patients who had high risk for more than 3 nodes, and significant less cardiotoxicity, obviously, with shorter duration of trastuzumab. If we look at the subgroup analysis, there are some patients who actually benefited from them, and this is early stage or less lymph nodal burden who benefited from it. So there is certainly some patients in whom it will favor the short duration of trastuzumab, but that didn't actually achieve in that trial. If we look at the Persephone trial, this is the only trial. This was a UK-based trial, and it basically shows that the overall survival and disease-free survival, they are pretty much overlapping each other. So again, this did demonstrate that this is non-inferior. So reducing the trastuzumab duration to 6 months was not inferior. So this was the only trial which was positive. So in summary, a short duration of trastuzumab may result in similar benefit as full duration in some patients. Again, we have to focus on in some patients, particularly those with a lower risk of recurrence, T1B or T1C and 0 patients. Careful consideration should be given in selecting patients for short course of trastuzumab. And obviously, cardiotoxicity, lower duration of Trastuzumab provides, obviously confers less toxicity, but improved overall and disease-free survival. Again, this is looking at cardiotoxicity. So patients who discontinued at 6 months or those who had 6 months of treatment, their ejection fraction improved much more quickly and had better or less cardiotoxicity. So we have covered the different durations of the HER2, 6 versus 12 months. Conclusions: individualized targeted treatment by risk of recurrence has substantially improved outcome for patients with early HER2 positive breast cancer, and dual blockage in the adjuvant setting improves outcomes. And patients who are at high risk of relapse due to lymph nodal involvement, 12 months remains the standard duration of adjuvant HER2, but short courses can be considered for some specific group of populations. Cardiotoxicity should not, risk and management of cardio should be considered when planning for HER2. So elderly, those who have cardiovascular risk factors, they should be, you should consider shorter durations if feasible. In summary, surgery followed by adjuvant paclitaxel and trastuzumab is recommended for low-risk patients, less than 2 centimeter size and node negative. Adjuvant pertuzumab in high-risk patients, node positive patients. New adjuvant treatment is standard of care for most early HER2 positive breast cancers. And after surgery, if they have not achieved pathological response, complete pathological response, then TDM1 instead of trastuzumab is better. Role of neratinib in some patients, specifically those who are ER/PR positive, HER2 positive, can be considered. Thank you very much, everyone.
Thank you very much, Dr. Imtiaz Khan. Our next speaker is going to be Dr. Said Iqbal from New Cross Hospital. He's a consultant medical oncologist, and he will give us a talk on early hormone receptor positive breast cancer.
Assalamu alaikum, everyone. My name is Said. I'm a consultant in the NHS. Thank you for the organizers for giving me the opportunity to present. So I will be presenting on the management of early hormone receptor positive breast cancer. So this is the agenda. I'll be focusing more upon the neoadjuvant bit of the CDK4/6 inhibitors and some important discussions we had this year from ESMO and ESCO. So as we know, breast cancer is the most common cancer in women, with hormone receptor positive comprising about 70 to 80% of all the breast cancers. So in terms of the incidence, stage 1 and stage 2 comprise more than 80%. And as we can see in stage 4, the 10-year survival is almost 11%. And in stage 1, the 10-year survival more than 90%. Hence the need for early intervention to help reducing the mortality. So this is a slide I took from ESMO. Essentially, it's a good algorithm. So basically, if the tumor size is less than 2 centimeters and the patient is fit and well, we'll continue with breast conserving surgery. If the tumor sample size is more than 2 centimeters and the patient wishes to consider breast conservation, we'll go for neoadjuvant chemotherapy. And the other scenario is the patient can upfront go for mastectomy and reconstruction later. I won't be talking about the chemotherapy benefit as my colleague has already discussed. So I'll be skipping these slides a bit. Also the chemotherapy regime bit as well. Okay, so this is an important slide. So all of us know that there's a benefit of CDK4/6 inhibitors in the adjuvant and the advanced breast cancer, but is there a role in the neoadjuvant setting? So let's look at 3 trials. So when talking about the palbociclib, there was a DX-Cartis trial. It was presented in 2019. So essentially, it was a phase 2 trial, and it has pre- and post-menopausal ladies. They are aged more than 18 years. And the Ki-67 index was more than 20%. These patients include like 2 to 3B early breast cancer, and the OncoType recurrence score was more than 18. So the trial design was patients divided in 2 cohorts based upon the recurrence scores. Pretty standard. They both had letrozole plus minus goserelin and palbociclib for 6 cycles. The co-primary endpoint was proportion of patients who achieved a recurrence score or pathological complete response. So in terms of the results, the co-primary endpoint was met in cohort B. So just a reminder, cohort B were the patients whose recurrence score was 26 to 100, and the recurrence score reduced less than 25, and a pathological complete response was noted in 6% of patients. So the question is, can the recurrence score be used as a dynamic marker in the future rather than a static one? What about the role of ribociclib? So Feline trial was similar to the GX-Cartis trial. Patients had letrozole and placebo versus letrozole plus ribociclib. Essentially, there was no difference. It's clinical, mammographic, ultrasound, or MRI response in the neoadjuvant setting, and surgery was similar in both arms. So far we know there's no role of palbociclib and ribociclib. Now let's talk about abemaciclib. So New Monarch was another study which divided the patient into 3 arms, basically only who had anastrozole, patients with combination abemaciclib, anastrozole, and abemaciclib. And the patient had co-biopsy 2 weeks after assessment, and the primary endpoint was Ki-67 index. So interestingly, the combination arm and the patient who solely had abemaciclib, there was almost 90% reduction in the Ki-67 expression. But I couldn't find data for the patients who benefited from in terms of the surgery. So in summary, we know that currently there's no current evidence from CDK4/6 inhibitors in the neoadjuvant setting, and we need data from phase 3 clinical trials. Okay, so since the treatment of breast cancer is changing every day, we have now prediction assays to decide which patients benefit the most from chemotherapy. But the indications for chemotherapy do include patients who had upfront surgery and afterwards either they were node positive, HER2 positive, or the tumor was more than 2 centimeters, or it was grade 2 or grade 3. Again, for low-risk patients whom we would not like to consider chemotherapy would be if the ER positive or HER2 negative, or the tumor score or the tumor size less than 2 centimeters. Sorry. So the 3 prediction scores, the most common ones are Oncotype DX, Prosigna, and EndoPredict. I'll be talking about Oncotype DX a bit. So this is basically a 21 gene assay. So the trial include patients from stage 1 to stage 3A. The tumor size shouldn't be more than 5 centimeters and also include lymph nodes up to 3. So it essentially gives a recurrence score to determine who will benefit from chemotherapy and who won't benefit. So the benefit is divided based upon the age. So in patients who are more than 50, there was no chemotherapy benefit if the recurrence score was between 0 to 25, but there was benefit if this recurrence score was 26 to 100. And if the patient are less than 50, they will also benefit if the recurrence score is 26 to 100. And if they're 21, 25, it's 6.5% and almost 1% benefit if the recurrence score is 16 to 20. Now let's talk about adjuvant CDK4/6 inhibitors. So this is a good summary. Basically, the 3 most popular CDK4/6 inhibitors, palbociclib, abema, and ribociclib. Palbociclib has not been beneficial. The hazard ratio is 0.93, which is not statistically significant. The monarchy, which is abemaciclib, which was quite beneficial. We'll talk about that. So in terms of the monarch, each trial, the patient were randomized to 2 arms based upon the high-risk category. The high-risk category was defined as someone who had more than 4 lymph nodes positive or 1 to 3 lymph nodes, and the tumor size was more than 5 centimeters. Essentially, patients had combination endocrine therapy along with the abemaciclib or endocrine therapy on its own. The primary objective was invasive disease-free survival. This is the latest 4-year data. So there is almost 6.9% benefit at 4 years. This translates into almost 25% benefit. So this is an important update from the Monarch trial from ESMO 2023. We do wonder at times that the patients who are PR negative may not benefit from the abemaciclib, but this was answered as from the update. As we can see, this clear benefit in both arms, irrespective of the PR status. Now let's talk about the NETLI trial. This was also presented last month at ESMO along with ESCO in June. So what does NETLI trial answers? The NETLI trial basically answers the role of ribociclib in the adjuvant setting. So just to summarize, we know that palbociclib is not beneficial, abemaciclib is beneficial. Now we'll be talking about ribociclib. Okay, so there's an absolute disease-free survival benefit of 3.3%. This translates into a reduced risk of 25%. So definitely this is beneficial as well. So subgroup analysis was presented at ESMO. There's benefit in the menopausal and postmenopausal status, along with benefit irrespective of the nodal status as well. So in summary, adjuvant ribociclib is beneficial in early hormone receptor positive breast cancer. The 3-year IDFS is 90% compared to 87%. We'll talk about hormone therapies in a bit. Okay, so this recommendation is quite a good one I found on the internet. So basically for stage 1A and C, we will consider 5 years of either aromatase inhibitors or tamoxifen. When it comes to stage 2, AI will be preferred as initial therapy, especially if the patient has globule histology, and we will potentially consider extended therapy. But if the patient has node positive disease or their stage 3, we will consider 10 years of treatment. Additional treatments also includes bisphosphonates to be given 6 monthly for 3 years in postmenopausal women, and adjuvant radiotherapy after breast conserving surgery. So I will also be talking about the latest developments from ESMO and ESCO. So this is an interesting talk. So basically, so patients who are ER positive and they're young and they want to become pregnant, there's increased risk of breast cancer if we stop adjuvant endocrine therapy, as this is contraindicated. So the positive trial answers this question. So the eligibility criteria for this trial was the patient understandably will be premenopausal, and the age was less than 40, and the patients had at least 18 months of treatment and no more than 30 months of prior adjuvant endocrine therapy. So the primary endpoint was the number of breast cancer events, and the secondary endpoints included the ability to become pregnant, pregnancy outcomes, birth outcomes, breastfeeding, and distant recurrences. Okay, so almost 516 patients had been receiving adjuvant endocrine therapy in this trial for up to 30 months, but this was paused in a way that there was 3-month washout period, and the treatment could also be interrupted up until 2 years. So this is an interesting data. So essentially, in the ladies whom we paused or stopped endocrine treatment, there was no increased risk of breast cancer events, with 8.9% in the patients whom it was paused compared to, 8.9 patients whom we continued, and versus 9.2% of the events. So in terms of the secondary endpoints, interestingly, patients also have almost 86% of the patients had live birth, full term or preterm. So in summary, there was no increased risk of breast cancer events in women after endocrine treatment interruption, and 74% of patients had at least one pregnancy, and 63.8% had at least one live birth. Okay, so an interesting talk again. So we know there is a role of neoadjuvant immunotherapy in triple negative breast cancer, but the role of neoadjuvant immunotherapy in hormone receptor positive breast cancer was demonstrated for the first time. This is from ESMO again, a couple of weeks ago. So this is a phase 3 trial, Keynote 756. So again, the eligibility criteria, the patients were ER positive, early breast cancer. They were randomized into 2 arms. One arm received pembrolizumab along with chemotherapy. The other arm received placebo along with chemotherapy. Both patients had surgery, and then one arm received 6 monthly pembrolizumab and the other arm received placebo. So the complete pathological response was observed in almost all the subgroups. So as we can see, the primary endpoint was met, and there was 8.5% benefit in the immunotherapy arm comparing to the placebo arm. So basically, in summary, Keynote 756 showed a significantly increased rate of pathological complete response of 24.3% versus 15.6%. The treatment difference was almost 8.5%. The benefit was consistent across all the subgroups, including those whose PDL1 was either more than 1 or less than 1, keeping the CPS score in mind, nodal involvement, and the ER positivity rate as well. At the moment, the results of other endpoints like event-free survival are still not mature. So basically, as expected, in the neoadjuvant phase, the grade 3 adverse events are more, 52.5% compared to 46.4%. So now we'll also talk about nivolumab. This was presented at ASCO this year. So we'll talk about Checkmate 7FL trial. So the key inclusion criteria, again, newly diagnosed breast cancer patients, early stage, grade 3, and the patient was stratified according to PDL1 scores, either at 1% or less than 1%, and axillary node status as well. Again, the patients were randomized to a chemotherapy arm combined with immunotherapy along with placebo arm. Patients basically had 4 cycles of paclitaxel followed by AC and surgery. And then in the adjuvant phase, the patient had almost 1 to 7 cycles of nivolumab or placebo. And the patient were followed up for almost 100 days. Again, this is very interesting. There was benefit of almost 10% in medium intention to treat population and 24%, which is even more exciting, with patients who had PDL1 more than or equal to 1%. So in terms of the adverse events, the patients had adverse events, not bad actually, just slightly more in the combination arm, which was expected. I think I finished early. So in conclusion, the treatment for early hormone receptor positive breast cancer has revolutionized over the decade. We need to understand there's an emerging role of combination immunotherapy in neoadjuvant setting at the expense of understandably more grade 3 adverse events. And when we talk about the CDK4/6 inhibitor, we need more data if there is any benefit in the neoadjuvant role. Again, a question is, will there be trials combining or head-to-head between CDK4/6 and immunotherapy in the future? Another question, what will be the sequence of treatments in the future? Thank you for listening. Yeah, finish my talk.
Thank you very much, Dr. Usaid. Can I have Dr. Habib Khan, Dr. Imtiaz Khan, and Dr. Usaid on the stage for a brief question-answer session, please? Thanks a lot, all of you, for excellent talks. Now we've got like 10 minutes question-answer session. So do we have a question from the audience, please?
I'm sorry. Thanks very much for the very enlightening talk. I have a question for ER positive early breast cancer.
Sure.
So in your practice, would you recommend ribociclib or abemaciclib? So if you draw the parallels between the two trials, so what would you suggest?
So thank you so much for your question. First of all, we don't know the right answer as the data is quite recent. But in terms of the UK where I practice, abemaciclib has been licensed. So currently I would suggest abemaciclib.
I have a question for Dr. Habib. So in triple negative breast cancer, after having Keynote 522 trial, and on the other hand, Olympia, Createx. So if a patient is having residual disease and the patient has received neoadjuvant chemoimmunotherapy, what would you, and the patient is BRCA positive as well, what would be your preference in adjuvant setting with residual disease? Thank you.
That's a very excellent question. It is a challenge that we are facing at the moment because we don't have the data available in adjuvant setting after the immunotherapy. So the ground is, there are few trials undertaken currently would provide us the answer. They were towards the end of my talk. So at the moment, what would I do practically? How should we approach this thing? We know that the residual disease is a harbor of a poor prognosis, and we have to escalate the treatment. So what should we do if they are BRCA positive and it has a residual disease, create X? Either you're going to go with the capecitabine first with immunotherapy, or you're going to go with olaparib kind of thing. These are the questions. Sequence point of view, we don't have an answer. We don't have an evidence to do it. What should I do? So if the patient is fit, well, and they have neoadjuvant pembro, AC, carboplatin, Taxol, and have a significant residual disease, either you're going to carry on. There is a role of immunotherapy. I'm not going to say it's not. Either you're going to combine the immunotherapy with capecitabine. That would be a thing. That's an option. I did that with the patient to carry on with cape and pembro, but unfortunately she had a risk like toxicity from pembro, so we have to stop it. So we carry on with capecitabine, and when they finish, if they have BRCA mutation, you can consider olaparib or PARP inhibitor at that point of view. That would be the rational approach, but I think it's open ground. There's no answer in terms of evidence. I would argument about it. Okay.
Hello, I'm Thilo Dirk from Hanover Medical School. Thank you for these excellent updates. And my question adds to the previous one, I guess. You said that 20% of your TNBC patients are BRCA positive, and there may be some role in olaparib, neoadjuvant chemotherapy, yeah, as suggested by the GEPA-OLA study. I'm not so sure whether there is also a difference in the PCR rate between BRCA1 and BRCA2 carriers in the platinum-based therapies or anthracycline-based therapies. So what is your experience there? And where do you see the future role of BRCA1 and BRCA2 mutation diagnostics in this context?
So if you look at the Keynote 522 trial and other trials that GPAR and UTO, they looked at the BRCA mutations and look at the role of carboplatin in those groups. There were, as you mentioned, there were no significant difference between the groups. Either you have a mutation or you don't. That established the role of carboplatin in this group. That's a strong indication. So I would use platin most of my triple negative. There are certain subtypes of triple negative breast cancer, like medullary, metaplastic, and they're not going to respond to any chemotherapy that you're going to do, but they have a very variety of mutations, and there's a very complex histology on those ones. In terms of using olaparib in neoadjuvant setting, if you're coming up to addressing those one, the olaparib did not show any significant benefit in having a new complete pathological response. So that was a little bit of a thing. May have with the pembro, may it have a different one? We don't know yet. There are a couple of trials looking into that moment. So I think the board is open at the space is there. We have to look for the evidence to come through and try to tailor it. As I say, we have to identify the high-risk patient and have to do. At the moment, I think it says a very careful discussion between the clinician and the patient in adjuvant setting, if you're talking about. Neoadjuvant, I think Keynote 522 trial has given us a very clear pathway, what to approach. And I have quite a few patients of mine had a very excellent response as well. And similarly, some of them, as I mentioned, you did not respond. So choosing our patient wisely at what disease, I think that's the key to it when you don't have an evidence to it. So we have to balance it rightly. I hope I answered the question.
Yeah, thank you.
Thank you.
Do we have any more questions?
Just in the interest of time, I'll go back to the question that Dr. Jamshed earlier asked. The controversy is there about which option to choose once you have gone for in triple negative pembro in the neoadjuvant setting, and what you are going to do if there is a residual disease, specifically the BRCA mutation. And you have to just take pragmatic approach because there is no definite evidence one way or the other which one you will use. If there is significant residual disease after the immunotherapy you have used, probably you are going to go towards olaparib, but it depends on patient response rate and that. And it is always a matter of debate when you are discussing these patients in the multidisciplinary rounds. So thank you.
Thank you very much. If we don't have any further questions, then I would like to thank all my speakers for the excellent talks, and we will end the session here. Thank you very much.
Thank you, everyone.
Thank you.